Chris, why don't we start with localized, and just to frame it, as we heard in the oral session, really important work that was done looking at understanding firstly the age-old question of when we do radiation, when we do surgery in prostate cancer. Maybe take us through that, and really pleased to see you're involved as well in this abstract. Maybe take us through the individual patient data from the 2 phase 3 randomized trials.
Yeah, so this is one of the things I have to say I love about ASCO GU. Makes it one of my favorite meetings is the whole multidisciplinary nature, right? We get our little silos at our urology meetings, the med-onc meetings, and here we really have a great mixing, I think, across specialties. And so you can see that even in the oral sessions, we have good urology representation, we have good radiation oncology representation, and we obviously have the stalwart medical oncology. So we started off the first 2 presentations heavy in the localized space. The second presented, but I would say when we think of disease treatment pathways, the first decision making in the context of high-risk localized disease. And just to reiterate, this is NCCN criteria. We're talking Gleason scores 8 or greater. We're talking PSAs of 20. We're talking clinical T3 disease. The question really is, how do we best treat these patients? There's obviously a backbone of localized therapy, and that comes into that forever debate about, should we do surgery? Should we do radiation? I think we could talk more about the details of this question, but fundamentally, high-risk disease is a systemic relapse problem more than a local relapse problem. And that's, I think, how we need to frame a lot of the thinking